Good afternoon, ladies and gentlemen, and welcome to today's meeting of the Adults, Communities Overview and Scrutiny Committee, which is taking place at County Hall in Glenfield. However, we will be joined by some officers who will be joining online via Microsoft Teams, and can I welcome any members of the public who've taken the time and effort to dial in to watch these proceedings. I would like to remind everybody present this meeting will be broadcast live via the County Council's website and will be available for viewing after the meeting. Can everyone please switch their microphone on when speaking and turn it off when finished speaking? We've only had one apologies for today's meeting, which is from Councillor Jewel Meir, and I don't believe we got a substitute, have we? Thank you for that. So agenda item 1 is minutes of the meeting held on the 5th of September 2022. I propose that the minutes of the meeting held on the 5th of September are taken as read, confirmed and signed. Is everybody in agreement? Thank you. Agenda item 2, question time. No questions have been received from members of the public. Agenda item 3, there are no questions asked by members under Standing Orders 7.3 and 7.5. Agenda item 4, there are no items which I've been asked to take as urgent or make that decision. Agenda item 5, are there any declarations of interest for any members in respect of items on the agenda?
Yes, sir. This is Joe Howell from Health Watch City and County. I am a company director for a care firm in the Leicestershire County.
Thank you for that, Joe, and welcome to today's meeting. You don't need to give a declaration of interest as you're not a member of the committee, but it's very kind of you to do so, and we will note it in the minutes. But welcome today. We regularly have somebody from Health Watch, and it's pleasing to see that someone has still joined us. So thank you for attending. Agenda item 6. There are no declarations of the party whip, that's I've been advised of. Agenda item 7. There are no petitions being presented under Standing Order 35. So the first substantive item today is agenda item 8, which is a report on progress in delivering the social care reform programme, which is set out on pages 15 to 22 of the agenda pack. This is being presented by John Wilson, Director of Adults Communities, and I believe that he's been joined by Christine Collingwood online. We have Christine Collingwood, who's the Programme Manager in the Transformation Unit, who's joining us online to assist in answering any questions. So I'll take it you're going to kick us off, John.
Thank you, Chair. So as you said, this is an update report to committee on our progress in delivering the social care reform programme. We've brought previous reports over the course of the last 12 months. I'll just start by drawing attention to paragraphs 4 and 5, which relate to the previous report that we brought to the last committee, which was focused around the fair cost of care and market sustainability plan submissions, which we were required to make to government by the 14th of October, and just to confirm that those submissions were all made on time. We haven't heard back from the Department of Health and Social Care, and as members may be aware, may have read in some of the media, there is a potential for the reforms to be delayed given the current cost of living situation and the financial situation the government find themselves in, and obviously we're awaiting the Chancellor's statement on the 17th of November, where it may be a further delay to some of the reforms would be announced at that point. Notwithstanding that, paragraphs 7 and 8 of today's report aim to give members of committee an overview of some of the key milestones that we would expect to see over the course of the next 2 or 3 months and our progress towards them. And we'll try to lay those out in a sort of a tabular form, just for ease, really. But happy to answer any questions around the detail of those. Paragraph 9 then goes on to talk about the charging reforms, and this is in anticipation that reforms go ahead clearly, but should the reforms progress, we will need to review our charging policy to take account of some of the new requirements, particularly around things like new threshold limits, capital threshold limits, care accounts, care caps, etc. But also we'd want to, within that review, ensure that we took full account of the Council's public sector equality duty, and in particular in relation to disability-related expenditure, which we signalled last year that we would want to review this year. This report is a sort of a forerunner of a potential further report to committee in the new year. Any review of the charging policy would require full public consultation, so we'd be bringing a report back to committee ahead of that early in the new year. The next section of the report just gives a little bit further information around some of our technical readiness and digital developments. And clearly, the reforms that we're required to make will require us to update our systems and processes, and system suppliers for our main database and charging systems are busy updating those systems, and therefore we'll need to implement new systems from April next year. So there's a little bit of information around that, but also around the fact that we're trying to move towards a more self-service functionality to allow people, particularly self-funders, to be able to undertake self-assessment themselves. Partly because we think that that's what people will want to do, and partly because it enables us to manage the increased workload. And then finally, the last element of today's report gives a little bit further information around preparation for the Care Quality Commission's assurance process and the potential inspections that they will be making on local authorities from April of next year. And it's our understanding at this point that should some of the charging reforms be delayed, it's unlikely that the assurance process will be delayed. So the assurance process is likely to continue from April next year. So in paragraph 27, we've just outlined the Care Quality Commission's proposed themes and standards that they will be assessing us against. We've begun to undertake a self-assessment process in advance of that. We've undertaken an initial self-assessment that's highlighted some areas which we've kind of noted at paragraph 32, where we know that we will need to think about improvement ahead of any assurance visit. And in paragraph 33, we're just outlining there that we would want to come back to committee sometime between January and March with a full self-assessment document for committee to be able to scrutinise that document and to ensure that committee are fully informed of the information that we're putting forward to CQC. Thank you.
Thank you, John. Do you have any questions? Leon.
Hi, thank you very much for this presentation. I have two questions. The first question is actually in page 20, paragraph 32. It is stated actually development of joint commissioning strategy with partner agencies. Can we have some examples of these agencies? Which are the partners? And second question is in page 21, paragraph 35. It states actually the CQC will engage with adult and community staff, elected members, volunteer sector, etc. How is going to be the selection, or how we're going to do the selection of the elected members to interact with the CQC? Thank you.
Thank you. I'll begin to answer, but I might also ask Christine if she wants to add anything to the responses. On the first point, the joint commissioning, clearly the main partner in terms of joint commissioning will be the NHS. Certainly at the same time that the CQC will be assuring the competence or otherwise of local authorities, they will also be assuring ICBs, integrated care boards. using the same framework. So they will use essentially the same, not necessarily the same criteria, but the same main themes for inspection and making judgments on that basis. So they would expect to see a read across between the assurance that they do for the local authority and the assurance that they undertake on integrated care boards. And within that, joint commissioning will be a feature. We've noted it as being an area where we think we need to develop further. So we know that we could work more closely with the ICB. Obviously, it's a new organisation, but there are opportunities to commission out of hospital care, particularly on a more joint basis. In terms of elected members, one of the themes that's outlined by CQC is around leadership. And leadership doesn't just relate to leadership through people such as myself in terms of sort of officers of the department, but it also relates very directly to members. And we would expect that the CQC would be seeking to assure themselves that members, and by members it would be the cabinet, it would be the Overview and Scrutiny Committee and the lead member, the portfolio holders, have an understanding of the adult social care strategy and how that's being delivered, and the outcomes and performance related to that. So we'd expect that they would want to speak to and engage with those members. But Christine, I don't know whether you want to add anything in terms of your conversations with CQC.
Not considerably more, I think, but it was very clear from CQC that they
Christine, we seem to be having some trouble with your microphone. I can't hear you at this end.
Sorry, I got locked out. And they would be looking for that clear understanding of, as you said, our strategies and key areas of work by elected members and their steer and buy into those aspects.
I think we've lost you again, Christine. So I think we're just
the adults. All right.
I think you've come back, but you keep disappearing. So I think we're just carry on.
Apologies there.
I think we got the gist of what you were saying. We did briefly discuss some of these issues at the chairman's briefing this morning and for members. And I think because there is an imperative, certainly for this committee, to understand exactly what's going on, we were talking about looking at a series of workshops early in the new year and to make sure we're fully up to date with what is expected of us going forward, if that meets with the approval of committee members. Do I have any further questions for John? So you got away easy this time, John. So thank you for the report. I think it is nice to see it set out in this format. I think it gives us a clear indication where we are. And again, let us wait and see what happens next week and see if that actually gives us a clearer pathway forward. Although I wouldn't hold my breath on that one. And I don't think you are either, John. So we're now moving on to agenda item 9, which is an update on the provision and procurement of community life choice services. These are the day services as set out on pages 23 to 28 of the agenda pack. John's been joined by the Assistant Director, Heather Pick. Welcome, Heather. And I don't know which of you is going to kick this one off.
I'll just briefly introduce and give the background, and then I'll hand over to Heather, who will take members through the detail of the report. So this report follows from a report we brought to committee in 2021, and we then presented a report to cabinet further in 2021, seeking approval to tender for procurement of external community life choice services, and at the same time consult on the potential withdrawal of the county council from direct provision of long-term community life choice services. We consulted On that basis, and Cabinet subsequently approved both the tender and the phased withdrawal of County Council from direct provision, and members of this committee asked for an update report at an appropriate time to provide assurance and reassurance on those issues. So I'll ask Heather now to go through the detail of how we've implemented those recommendations.
Thanks, John. So you'll see in the background that we had 10 building-based day services provided by in-house, employing 43 full-time equivalent staff across various locations in the county. We also had the largest market share of our day service provision but from the independent sector at that time. So we were looking to end the long-term provision of day services and concentrate on the short-term reablement enablement end of community life choices with our in-house services, focusing on reablement, crisis care, etc. Sorry, my computer seems to keep freezing. So we went into, as John said, a procurement for the new community life choices framework and closed to bidders on the 27th of September, and we received a number of responses. We did recognise that within the independent sector there was a deficit in the market for our most complex people with multiple learning disabilities and physical disabilities, and we were looking with that procurement to secure some extra resources for that end of the market, which we have done, but not to the full extent. So following the approval by Cabinet in December 2021, we went out to, as John said, seek permission to transfer people following review of those services and with a transition packages to alternative providers in order to meet their daytime needs. There were 112 service users registered with the in-house services, and of those 112, to date, we have transferred 93 individuals into successful alternative appropriate services. The service manager of that service has given some examples in the paper of people's transition and the successes there. We have 19 service users where an alternative provision has been identified, but have not yet moved. And the current in-house services in a table on page 26. So we have the Trees closed, Timber Street, Wigston closed, Community Resource Centre, Colville closed, and Hood Court, Ashby closed. We have 5 people left at Roman Way, 2 at Bridge View, and Carlton Drive 4, and Charnwood 8. So total of 19 we've got still with us. The majority of those have got transition plans, but they haven't yet transitioned. We do have a few people who it's proving very difficult to find alternatives for, and we will continue to provide those services until such time as there is an alternative. Our long-term services are provided now at our short breaks unit, so we do still have a daytime service for people. So we are confident that we can manage that transition of those people going forward. We talked about the staff at those community life choice services, and of those 43 staff, we've had a number of successful redeployments within our other in-house services, so short breaks, our home care assessment and reablement teams, and our crisis response teams, and we've had to date 13 redundancies out of that 43. I'll pause there for any questions.
Any questions, members? Barry.
Thank you, Chair. think there was one area. I mean, obviously, when we had this before us and we discussed, you know, and especially I think I mentioned myself, I'd like to see is, you know, a report back on how well we're doing. And obviously, we've managed to find places for 93. Now, there's only the one example of a successful one in here, and I've just put down, is this the norm? I mean, the data I'd like is out of that 93. I'd like to find out how many are actually happy, how well we've done as a council in moving people forward. That's a great example, but we got 93 of those, or just the one, and 92 other people that are not very happy. So I quite like that.
So I haven't got evidence that people are not happy. I do have evidence they are attending their alternatives, and we have a regular review process, which includes not only our in-house, but also other people, everybody that we commission services, we have a review function for, and the reviews coming back are saying that those people are attending and that they are moving forward with their opportunities. So, but happy to provide more examples.
Yeah, and I think it's quite often it's the families that have the concerns, and I certainly had people get in touch with me in my division, but I haven't actually had anything since. Moving on to that, so when it comes to Roman Way, which is in my division, I'd really appreciate an outside this meeting, just a report or something, just where we are on that, because I think I went for a visit with Zubair, etc., and looked over, etc., got involved, and it'd be just quite nice to get an update for my own division, so I can just keep an eye on things and I can share with my other members, etc. And on the redundancies, obviously you've answered the question. I wondered how many there were, etc. so far. So glad to see that we're able to find as many transitions as possible. Thank you, Chair.
Linda?
Thank you, Chair. 13 redundancies so far. Are you expecting any more redundancies? And these providers now that are taking on the in-house thing, have we got extra providers, or is this going to existing? And if so, how many providers do we have that do this service?
So the redundancies that we've had so far are as part of the action plans. So there are no more planned redundancies. There may well be people who are in temporary situations that don't want to continue, etc. But at the moment, the action plans have been completed for those services. For the staff, for managers, that's where they have been redeployed on a temporary basis. But we're very happy to have retained their services, and obviously they're very knowledgeable managers, and within our in-house services that we still retain, then they're valued there. So we don't anticipate any more redundancies from staff. For the providers, we yes, as John said, we did have a procurement, and that resulted in extra providers. I'm just looking to see in the report whether it tells us how many. Paragraph 12. Very slow internet. Yeah, so 16 providers included an application to deliver services, including the applications for those people with profound and multiple learning disabilities. 27 providers successfully joining the CLC framework. You're right, I don't have a figure of exactly how many there are in total, but there were 27 extra applications. Interestingly, in the Market Harbour area, where we were struggling for just those providers, and we were anticipating difficulties transferring people, that's where we had the extra interest in profound and multiple disabilities. So we've successfully been able to move people on in that area because of that new those new providers. But we can get you the total number of CLC providers. Obviously, we do commission services for older people, for community life choices, etc. So, there are more providers than just the profound and multiple disabilities providers.
You look like you want this to come back, Linda. Leon.
I didn't see the redundancies actually in the document. So can I ask a question about the redundancies? We all know how difficult it is to find actually experienced staff, skilled staff, and how much effort we put actually to train all these people. When we go to redundancies, is any scheme or any program for redevelopment or redeployment, or we just put this down to efficiencies?
So I can tell you that the redundancies were of staff who were taking retirement. So they were wanting to take those redundancies and not return to another job, etc. We did have plenty of redeployment opportunities alongside retraining programs, etc. within the council for people who wanted to remain. But the 13 individuals either had another job to go to, or outside of the council, or they were looking for they were at retirement age.
I just wanted to ask you about the numbers in the case, because it's got here, there's initially 112 service users. So that is the total, is it, of the short-term and long-term service users?
They were all long-term.
They were all long-term?
Yeah, they don't.
Okay.
Yeah.
All right. So when we go down then to your chart indicating 19 left, are they all long-term as well?
Yes, they will have been people who will have had a longer term commissioned with us. The length of time they've been with us can vary, because when we say long term, we mean that they have a commissioned service from us. It's not just a time limited intervention. So that somebody could have been with us for 6 months. They could have been with us for 6 years, but we class those as long term service users.
Will be going to someone else now, will they? And we're just looking to place them.
As with all of the other 93, we have review officers who work with them and their families to look at what the alternative provisions are and match them with the provision that suits their needs. So that's no different for the 19. The 19 have just been more problematic because of the area, etc., and their wishes to transfer.
So, and again, I may be being immensely thick, but just in terms of clarity, the council then is still going to be responsible for crisis CLC and short-term CLC, but none of those figures are within this report. How many are crisis and short-term?
So,
sorry.
So what we've been concentrating on is a longer term provision for these 112. We've done that for many years. What we have found is that there is more and more need for carer respite, for people who are going into crisis, etc., for us to work with them to get them more stable, in a good place, and to be able to then resume a longer term provision. We haven't been able to provide that, and there isn't anything like that out there with the independent providers. So we wanted our in-house expertise to be able to focus on that element. So none of these were short-term crisis cases. These were all long-term provisions, and we probably get 3 or 4 a month that come in for crisis or short-term provision. And we do have our short breaks units, which are 24-hour operating short breaks that we can provide that service in.
Sorry, just in terms of proximity and the providers. So for instance, the trees in Hinckley, in terms of that, who's taken over, as it were, providing the long-term services for the people who previously were at the trees Hinckley, and is that provision within a reasonable proximity to those people?
So the procurement framework looked at providing services on people's locality basis. So we had a range of services around the county, and people bidding for those particular services in those areas. Where we've been able to, and where people wanted to, we've matched them with the new provision in their local area. There are different providers providing different types of activities, etc. So it could be a range of providers in the same area that the people have transitioned to. But some people have chosen not to go to a traditional day service. They've chosen to have a direct payment and purchase different activities. Some people who were attending those day services didn't necessarily live as close to those day services as other services that have opened up. So there has been a range, and we have got a full list of the providers and the services and the areas that they cover. But it wasn't as simple as taking a group of people and matching them with one provider in the same area. It has been a truly, independent individual review to match people with what best meets their needs now and can enable them for the future. So it has been quite a big exercise.
Just wondered, in terms of the short term and the crisis CLC, whether we could have some kind of figures in terms of the last 6 months and probably going into next year as well, just so we can get an idea. It was 3 to 4 a month. That's not very many. And it makes you wonder whether that provision by us in totality is worthwhile if it's only 3 to 4 people per month.
Very happy to bring the report back next year. As you say, it's probably helpful to sort of go back 6 months and forward 6 months so you get a full picture. I suppose what I'd say about whether it's economic to provide that particular service, as Heather said, we provide that service from our existing short breaks services. So we have 3 short break services in the county that are open 24/7 and have the ability within them to provide short-term CLC services alongside the people who will be staying for respite care. So in terms of the efficiency perspective, we're providing it from a service that's already in operation. So we're not developing anything new or in addition to deliver that service, but we happily bring back a report.
Linda.
Thank you. Just following on, really, is there an independent provider that does the crisis? Because I would think most people would come to the local authority if there is a crisis, and I accept that it's done in the short breaks. The other thing is, could we find out, or could you let us know what services now is left for learning disabilities? Because, gradually we are diminishing the services that we provide, and it would be nice to know actually what we do provide and what is left. Thank you.
Thanks, Linda. Perhaps if I could suggest, John, that we add those 2 points onto the next agenda setting, which Linda will be out and work out the best way of bringing the appropriate information back, whether it's through a report or whether it's through information. Clearly, it's something that members are interested in, and if we can just give it a bit of thought, the next agenda setting, we can come back in the appropriate way. Just a final point from myself is we're now down to, I think it's 19. Now, there must come a point. I appreciate the way we've done this, which is the right way. We've done it sensitively. We've done it managing each individual need. Presumably, there must be a point when we have to have a cut-off date to say this has got to come to an end, or are you saying that within the provision we currently have in-house, we may just have to transfer 2 or 3 people into that provision, so this part comes to an end, but those people will be dealt with somewhere else?
Yes, that was the commitment that we made, that we would reduce the services and close buildings as people transitioned. But but the commitment is that if we are left with any people that we can't find a suitable alternative for, we transfer them to our own in-house facilities that we've got alongside our short breaks. So people won't be left without a provision.
And do you have any thought process on the timescale for that?
Well, I'm reliably told that most of the 19 have a transition plan. We're just working through that. So I would have said that at least by April, we will be in a position to know those people who are going to remain with us where there isn't a provision and have transferred the rest out.
Sorry, Mr. Chair, just in terms of the type of provision, is there a specific type of provision that's proving more difficult than anything else to kind of provide in terms of an outsourcing?
Yeah, it is those profound and multiple learning disabilities. So those people who have extreme physical needs, so hoists and to carers those toilet facilities, washing, dressing facilities that need to be on hand, as well as the activities. They're the people that are you know, obviously not easy for providers to transition unless they're specially providing that type of service. Because we can do this at our short breaks facilities, which have 24-hour care and overnight facilities, we can accommodate that. So we will do that.
Thank you for that. The reason I asked about the timescales, it maybe we can wind that into a report that covers everything, the wind up of this, how it's transitioned in, and the two aspects we've currently done, rather than have lots of multiple reports. And we can work that best in with the agenda if that suits all members. Right, thank you all. We're now moving on to agenda item 10, which is managing demand in adult social care, as set out on pages 29 to 40 of the agenda pack. And we're staying with the same duo. I won't come up with a name for the duo, but I shall let the duo decide which one of them is going first.
Thank you, Chair. Yeah, I'll do the same again if this is all right with the committee. I shall briefly introduce, and I'll hand over to Heather for the difficult bits. So this is a report that we haven't brought to committee before, but we particularly wanted to ensure that committee was cited on some of the demand challenges that we are facing in Leicestershire, but equally are being faced nationally. And I think certainly there's been a lot of media coverage of demand within the NHS, and latent demand within the NHS, and unmet demand within the NHS. Less so in social care, although I think possibly over the last 12 months there's been perhaps a growing kind of awareness of some of the issues in social care, particularly in terms of unmet need. So what we brought is a report which outlines some of the national context. It provides information for members on the current position with people waiting for assessment or waiting for care or waiting for a review in Leicestershire. And then there's a little bit of analysis of how Leicestershire compares to sort of the national position. We've set out a sort of a policy framework, just in a few kind of paragraphs at the beginning, because we felt it was helpful for committee just to understand the requirements on the authority vis-a-vis the Care Act and the duties that we have within the Care Act. It's worth probably noting that there is no set time frame within the Care Act for an assessment to be carried out. The Care Act talks about a reasonable time frame, or it talks about an appropriate time frame, but it doesn't actually stipulate any particular time frame. Generally speaking, our position has always been that it should be reasonable in most cases to carry out an assessment within 28 days as a reasonable time. But obviously that's dependent on circumstances of the individual, whether we have to seek further information from other professionals, etc., etc. But that's why within the report you'll see, as we go through some of the detail, that we have a sort of an overall number and then a number that's over and above 28 days for assessment. In terms of review, the Care Act is more descriptive. So the Care Act does require that everybody should have a review of their care needs within every 12-month period. So without further ado, I shall hand over to Heather, who will go through some of the detail in the report.
Thanks, John. So yes, as John said, we haven't brought this type of report before. Obviously, through our oversight and governance, we're constantly looking at what weights we've got and how teams are managing demand, etc. So we have a good oversight. In saying that, it's really difficult because each case is is different. You can have cases that present with the same scenario, the solutions are different, the timescales are different, the amount of professionals involved are different. So it's been quite a good exercise for the department and for the teams to actually put together the information that we've done for this report. We've got data, but the data is numbers, isn't it? What we were looking for when we did a snapshot audit with the managers was to actually get some more quality data and some more softer information on what types of weights, what people are waiting for, you know, and some of the challenges that we've got. I think it's fair to say that it's been a hard and tough couple of years, and that the COVID pandemic did make a difference to the types of cases that we've had through, the types of risk that we were carrying, etc., and the solutions that people were able to put in to meet some of those Care Act needs. But we're hopefully coming out the other side of that and getting to a more normal pace of demand and work coming through. We looked at the thing that really prompted us with this was the ADAS survey that was wanting to, I think, outline how difficult it had been and how numbers for weights of assessments and support packages had increased across the country. So we took part in that, and we were reassured that we were, if you like, no different to any other local authority, and in fact we're probably performing a little better than the average. So we were reassured by that, but again we wanted to look in more detail about the actual weights that we'd got ourselves. Compounding that was in April this year, we implemented our establishment review. So that was a major restructure for the department and teams. In response to the target operating model that we'd implemented before COVID with our partners, Newton and Europe, which reports had come to this committee. So that was the target operating model and the model going forward, and for the changes that our partners were having in their agendas around discharge to assess and the acute care sector, and expectations that the department would be able to meet those increased demands. The restructure then, I've put in here just a flavour of the new teams and the new remits of the teams to give you some understanding of how the service operates. At the front door with the CSC and our Home First teams, which predominantly respond to the demand from hospital and crisis of people in the community, and our operational commissioning teams, who then are focused more on the long-term provision of people with disabilities and longer-term support needs. In paragraph 22, I've put a table in to show you what the demand during the last full year of data collection was, just to give some context of how much activity is coming through, and where we've got the data from for this. In paragraph 25, we show the amount of weights per service area. So I've concentrated on Home First, cognitive and physical disability, learning disability and autism, mental health, occupational therapy, and deprivation of liberty standards. You'll have seen in the previous information, there are many more teams than that, but we tried to match this with the national data, which collects the information on these specific areas so that we could have a true comparison. All of the teams did submit their data, so we had that richness of the whole department, so we had a good overview. On 27, we've got the overdue reviews, and as John alluded to, we count an overdue review as being over the 12-month statutory period that we are required to do it within, and so that gives you the figures for our reviews of people who are currently receiving services. It goes without saying that if people need a review before that 12-month period, then they will receive an earlier review. We're bound to review people on a 12-month basis where their package is stable and seem to be meeting their needs. But if people go into crisis or have different needs, then they would come back into the system for an early review, and they won't be counted in here because they will be before the 12-month period. That's the requirement. New referrals that come through the CSC are either resolved at the customer service centre by onward referrals to our partners or other agencies, or advice and information, simple pieces of equipment, etc., that can be dealt with by the CSC. All of the cases that need a more specialist involvement are transferred through to our care pathway teams for follow-up. We do operate an urgent function on a rota basis, so all of the teams have a duty base. So any case that goes into crisis or a new referral coming and needing immediate response, we'll get that through our urgent function. Again, those people won't go onto this list because they won't wait. They will have their needs met immediately, their immediate needs met. If they are stable but still require further involvement, they would then go on that waiting list once their immediate needs are met. The managers of teams review on a weekly basis the unallocated cases and reprioritise on the risk basis or the time that people have been waiting. So that's done on a weekly basis, and cases are allocated either on an urgent basis or on a weekly allocation. Through our target operating model, we introduced case progression sessions for our individual workers, in addition to their one-to-one supervision sessions, and they are still in place and operating well. And requests for new DOLS assessments, so deprivation of liberty safeguards assessments, are prioritised in date order. And there's a framework contract in place to procure independent assessments to increase capacity and manage demand. All requests for renewals, which are in effect reviews, so they're people who are already have had their assessment, but they're still in the service, are up to date. So we're sure that people in the system who are requiring a deprivation of liberty review have got them. We also on paragraph 34, I've tried to look at how we organise our wait lists in priority order. And so when cases come into teams, they are triaged into a priority of low, medium or high. That helps when team managers are reviewing their lists on a weekly basis to allocate, and that's used to make sure that that the risks are managed within that wait list. We looked at the national data is refreshed every 6 months, so we've looked at the most recent refresh to see if we are still performing as we were when the April figures came out, and we seem to have had a slight reduction in the amount of waits that we've got compared to the national picture, but there are still more people waiting now than there were this time last year. I went on to look at resource implications, and obviously we've had a number of vacancies, and I've outlined there that when we had the restructure following the establishment review, we had 49 full-time equivalent vacancies. That did reduce to 19. We do have a turnover of staff, and to impact on that, we do have a level of sickness and absence, which we also have to manage. But we are in a better position than we have been for some years in regards to recruitment. the number of people waiting for assessment or review could affect our financial forecasting. As I have already explained, where people come through to the teams and they have an immediate need, we will commission on that need and we will stabilise a package. So we will be spending money on those people, even though we haven't done their assessment or their support plan in order to stabilise their situation. Until we've done that assessment and put that support plan on the system, the financial implications of that provision aren't forecast in our finance forecasting. So I suppose I'm saying there could be a number of people who are already receiving services that we're not forecasting on because we haven't put the financial information into the oversight. Social care reforms you heard earlier, or tried to hear earlier. Sorry about the IT. Could see significant increase in the amount of assessments that we need to do and the activity that we do with people who are self-funding currently. So the impact on people waiting and on reviews, we've yet to see. We have some work, as we've said, going on to look at some demand and capacity information, but it's a real risk for us with the staff that we've got and the lack of clarity, shall we say, about funding for social care reforms. I think I went on to in the conclusions to say that managing demand and associate risk is a core part of our activity and it's expected. The COVID years did have had an impact, but the work that we did on the target operating model, I think, saw us in good stead for that and has a robust leadership and governance approach that means that we are able to constantly refresh and review what we've got waiting and make sure that those cases are allocated in the most timely way that we can. I think the audit for us as a department did give us assurance that we've got the information and the experience that we need to manage those waits within the resources that we've got currently. And we do have weekly and monthly performance management meetings to look at that information. John's already said that it's expected that we'll always have some waits. We'll never have no waits. We do expect that our new referrals are allocated within a 4-week period and that people in receipt of services are reviewed within a 12-month period. I've already said about the increased demand coming through post-COVID and our recruitment and retention issues as part of the restructure. We recognise that although the teams, through the audit that we did, could evidence that they'd got a robust and consistent way of prioritising and triage cases, we don't have a policy document that actually sets that out and that people can refer to. That's more of a custom and practice and good oversight by senior managers. So we have said that we will put that in place and we've got a part way through that now. So that will be in place very shortly. And again, the overall position in Leicestershire is consistent with the position experienced across all English authorities and compares favourably in some areas. And as you can see in paragraph 57, we do have an improving trajectory, even though we would still like people not to have to wait for the length of time that they do wait. I think that's the report.
Thanks for that. Linda.
Thank you. Very comprehensive report. It's a catch-22 situation. You know, you're going to get these referrals and you're talking about recruitment and retention, and it's not a bottomless pit, I accept that. But what do you consider, or do we know how many cases are allocated to each worker? Because the pressure for having to do all this, you know, and we restructure because of costs, but the pressure on some staff must be horrendous. My sister was a social worker for Leicestershire County Council for the Children's Service. She took early retirement, very early retirement, because the pressure was just too much. And, you know, it does affect staff. So how, you know, something urgent comes in, it's got to be dealt with there and then. But what I'm trying to get at is how many cases do you consider one worker should be allocated at a time? And I know you said it's reviewed each week, but if somebody's allocated 50 cases, that's a lot of pressure on that person, and for us to be able to keep that person under the pressure. And I know it's difficult, and that's why I say it's catch-22. You know, we haven't got the money to employ more people. Cases are still going to come in. So, but it's trying to find out how that is managed, really, so that we do retain staff.
So I think you're absolutely right, Linda. We, through the target operating model, that was something we looked at really closely. And one of the reasons that we have the amount of weights that we've got now is because we carefully manage the amount of cases that we allocate to workers and they're expected to hold. So we, that's why we triage and review our weights frequently. Yes, we do want people not to wait too long. We want them to be allocated, but we also want our workers to be able to manage the cases they've got. So our benchmark for a full-time equivalent worker, this is middle of the road cases. So some case, if you've got really high complex cases, court cases, etc., it could be less. If you've got reviews and maintenance cases, it'd be less. But our benchmark for a full-time worker is no more than 25 cases. And our throughput for those cases, we are looking at 1 to 2 cases per week. For social work cases, we're looking at 3 cases a week for our unqualified community support workers, and 3 to 4 cases a week for review officers who are reviewing people who have got packages already that are relatively stable. So in that way, and monitoring it, with that level of frequency, we hopefully can make sure that the workload is manageable for the people who are working it. If things come in urgently and need allocating, yes, we will look to the most appropriate person in the team, but that's why we have a duty function, so we can allocate short-term intervention pieces of work through that duty function, and they'll be dealt with so that cases are stable and then can go on the wait for an allocated worker. It isn't rocket science, you know. We can't do this without the staff, and we need them in working. So we have a lot of emphasis on trying to help workers manage their caseloads and their throughput.
Hi. Just looking at the home first bit. It seems to me that home first kind of encapsulates quite a bit, doesn't it? Including the short-term intervention and the hospital discharge. That's all rolled into what essentially is called home first, is that right? So, say for instance, the operational commissioning, that seems to be broken down a little more into actual formal categories, whereas home first does not. The specific area of concern for me is the hospital discharge arena, and we're approaching the time of year now where, of course, that is a predominant thought on a lot of people's minds in terms of bed blocking, etc. And looking at the statistics for home first, the statistics again are very generic. They're not split and further categorized. 28 days in terms of an assessment for a care plan for someone who is in hospital can have a significant ongoing impact in terms of emergency, hospital provision. So I'm just wondering, one, whether you would be able to split up home first a little bit better in terms of categories, and 2, whether you could split it up a little better in terms of percentages, so we could actually see the relationship between hospital discharge, the effect on hospitals, and us. Sorry, it was a long comment.
No, that's fine.
In fact, I'm not sure it was a question, but
Yes. Well, I'll try and respond to what I think is the question. And Heather will probably want to talk about the actual practice. I think it's fair to say that you're absolutely right. Home First is our sort of most of our assessment activity would go through Home First. It's, I wouldn't call it the front door because I don't necessarily like that terminology, but certainly we would direct most of our new work through the Home First service. And we often look at a separation between existing people who we currently support who might want a change of service and new people to the department who are looking for a service for the first time. Certainly those new people, the vast majority of those, if not all of them, would go through Home First initially. And it does include all the hospital discharge work. And we can certainly provide detailed information around the hospital discharge work. We have reams and reams of performance data around hospital discharge, as you would imagine. So we can provide you with all sorts of information around the numbers of people that we have referred to as from hospitals, the types of provision that those people are seeking, the length of time it takes to enact that provision. It doesn't take 28 days for a hospital discharge assessment to take place. It's 1 to 2 days in general. Often, and because of the recent policy changes around discharge to assess guidance, we often will discharge people prior to the assessment taking place. So we'll put a safe service in, and then we'll undertake the long-term assessment of that individual, whether they're at home or whether they're in interim care. So the definition of kind of home first, I suppose it's perhaps not as obvious when we talk about Home First. It's not quite as obvious as a sort of a long-term team working with people with learning disability. You can kind of picture that in your head. You know, traditional social work service. Home First is something kind of new and modern and different. So I'm very happy to provide further information around that. Anything you want to add?
Only that most of the client group for Home First will be older people, and a significant amount will be people who are coming to us for the first time, having had a significant health episode. And John's right, the discharge to assess process means that we can discharge people from hospital with limited information based on what their discharge needs will be. The term Home First is born out of us and health wanting people's needs to be considered to be dealt with at home in the first instance. As you know, a lot of hospital discharges relate to interim care or long-term care. But that situation, and I alluded to it in some of our risks, means that we will discharge people with services without a full assessment and without a financial assessment for their contribution. So that rapid turnover means that people can get out of hospital, they can have support, and they can have their assessment at a later time. We still would like that assessment to be done much sooner than 28 days for obvious reasons.
Thank you. That's given me some degree of reassurance. It was just that at paragraph 25, when you're looking at the Home First numbers, waiting less than 6 months percentage says 0.1%. And in my mind, I would envisage that quite a large proportion of what you're talking about here is hospital discharge. And so that just didn't make any sense to me. So if I could see some further statistics on that, that'd be wonderful. I've got one other question for you, and I'm sure this will be quickly answered. It is in relation to the mental health figures and the medium and high. I'm just trying to find which paragraph we're at. Thank you. Yes. And I noticed, you know, the high in general is, you know, quite a large percent, because you'd anticipate that people are going to deal with the high risk, albeit more complex issues as a matter of priority. But there are certain areas there, including my concern was the mental health, but, you know, there's others as well, where all the medium kind of levels. are in excess of the high levels. And I'm just wondering whether we are focusing enough in terms of the staffing for the high complex cases, which are going to, of course, be longer, more drawn out and more complex than we are the medium range, and whether we've got our allocation of resources right in that regard.
So these priority areas, it's very difficult to say that this particular case will go into a high, medium or low. As I've said, it depends on the circumstances of the person. You can have somebody who has a lot of needs but has a lot of support already, etc. So their same presenting need would be a low risk to us because they've got support around them. So it is quite subjective, and it's at triage where people will put these categories in. These are social care risks. So somebody with a very high mental health risk would not be in this list. They would be on the on health's list, etc. And so they're high risk to us. So they need support. They need an assessment and support, but they're not at risk of admission to hospital or that sort of thing. Oh, sorry. Yeah.
So,
yeah.
I just said to Heather. So what we've done in the appendix is given an indication of the sorts of areas that might determine whether it's a high priority or a medium priority or a low priority. So when we look at our wait lists, we're just doing a sort of, I suppose, a bit of a rough analysis of how many of the people waiting are
And what
would be
they're
considered
waiting
high
for,
priority, and how many people might be considered a medium priority.
And that's for allocation basis.
I'm not sure whether it answers my question, because again, I would expect the high risk arena to be higher than the low risk and medium risk in terms of percentage that you're assisting with. No? Okay, then that's fine. I'll pass.
Nick next, then Leon.
Thank you, Chair. We're looking here at this, and we're on about discharges from hospital. Where into the figures, people who have to keep going back into hospital, whether it could be for long-term pain management or other things, have to go back in and then coming back out again for other reasons. Where do those kind of people fit into these figures at all, please?
I would think that they would be in the mix, as it were. So we wouldn't identify those people separately. What we do, as I said earlier, is we do identify and we do characterise people as being either new to the authority, or people who are existing service users, or people who are existing service users with an increased level of need. So it might be that those people would fall into that latter category. So if they've been in hospital, they've received treatment, they've come out of hospital, they're receiving a service, and then they go back into hospital, and they come back out of hospital with an increased level of need, then we would see them in that categorisation on our performance data, but we haven't separated those people out in terms of this process, if that makes any sense.
Leon.
Thank you, Chair. Bear with a few questions. When we go to page 30, I would actually call it the elephant in the room. This ADAS report is giving actually an increase by 44%. Now, as I said earlier to colleagues of mine, if in the area of work we have an increase 44% in infections, I will have 20 agencies jumping in to find out why. What actually this report does not really offer here is an explanation. So there are a number of explanations I can give, but actually I think the most likely explanation is actually the NHS is pushing the patients out of the hospitals to go towards actually the adult social care. It's obvious. And correct me if I'm wrong. The other possibility is actually to have too many patients with post-traumatic stress syndrome following COVID, but nobody is trying actually to explain why actually we have this massive jump in demand. So I don't really know what's the answer, what's the real answer. All of these are my assumptions. But when I go down to page 35, there is something which I find very strange. Although the increase in demand in Leicestershire is similar, 34.7 compared to 36.9, the number of people, the percentage of people, especially waiting for assessment, which increased nationally by 30.2%, here in Leicestershire, actually, it increased only 4.6%. And farther down, there was a national increase of 39.8%. But here in Leicestershire, actually, there was a decrease by 4%. So there's actually a serious anomaly in numbers. So either actually we are extremely super efficient or effective, not to say efficient. And if we are so effective, can we teach other councils to do the same? And what is the explanation for all these things? Before I go back to the table Councillor Wright was referring to in page 35. I strongly believe actually just giving percentages in these columns is confusing. I think actually you need to put the actual numbers plus the percentages, because you see, for example, in occupational therapy, you have 10,000 patients, and in mental health you have 10. Or the percentages are totally confusing. Thank you.
I'll go first, and then Heather will tell me I'm wrong. But anyway, so in terms of the overall demand increase, I think there's a couple of issues there. The first is that you're probably absolutely right in that by far our highest increase in demand is in hospital discharge, and it has been for the last 2 years. And we can see that through our performance data. And that has been driving demand in adult social care at a rate that we've not seen before. And it's for obvious reasons, because the NHS itself is under pressure, and so the whole system has latent demand, whether it's from primary care, whether it's through to secondary care, and then into social care. So there is this kind of whole system issue, which is kind of feeding through. The other issue I would say, though, is that organisations, particularly organisations like Age Concern, Age UK, and MENCAP and other national voluntary sector organisations have been saying now for some years, and pre-pandemic, that there were hundreds of thousands of people whose needs were not being met by social care. And they've been arguing that point for some considerable time. I don't think there's ever been a national collection of data to evidence that view, but clearly this data is now beginning to show that they were probably right, that there's a whole host of people whose needs are not being met, or whose needs are, for want of a better term, being undermet. And I think this probably just evidences that. In terms of the fact that it's increasing at such an exponential rate nationally, and compared to the figures in Leicestershire, the first thing I say is that the national data was based on, and I think it might mention it in the report, but I think it's based on around about 85 authorities out of 150, so it was extrapolated. And there was a difference between the first survey in April of this year and the second survey in August of this year in terms of the number of authorities that responded, and so there might be some issues there about data quality, possibly. Certainly in Leicestershire, one of the biggest factors is, and it's referred to in the report, is the fact that we moved from having 50 vacancies to having 19 vacancies. So clearly that has a major impact in terms of our ability to manage incoming demand. And if we can maintain a level of workforce at that level, and hopefully, go further in reducing our vacancies, then that will have a significant impact in terms of, because as Heather said, we have an expectation that people complete 2 or 3 pieces of work a week. Or if you've got an extra 30 staff, that's an extra 100 pieces of work a week that you can plow through. So that will have an impact. And are we more efficient? Well, possibly. Heather, I don't know if you want to.
I would say that because we were fortunate and did our target operating model work pre-pandemic, as I've said before, that gave us a robust performance and monitoring and a rich data information to be able to manage the demand coming through and to make sure that we had got that throughput. I think that is what has made us more efficient than probably other authorities that have been in this survey, and more efficient than we were before we had that operating model. So we have seen our performance even on the even on the stuff that we had pre restructure improve quite considerably. So that maybe would explain why we were able to buck that trend a little, and hopefully we can continue to do that.
And how do you teach other authorities? How you transmit actually your experience, your preemptiveness, your effectiveness? How you do that? Because practically, it's good actually to be sitting here and say we're wonderful, but actually the entire country is suffering. So if you know something, you do something, how do you project it?
So we're constantly asked, aren't we, John, to provide information and presentations to our peers and colleagues across the country, and part of the conferences and part of the work of Newton Europe going on means that they use they had a lot of information. They did videos, they did training packs, etc., based on our experience through that, and that is being rolled out across the country to those local authorities who want to take it up. So, but we are constantly asked to be providing or presenting in sort of regional and national arenas the work that we're doing. So we're proud of that.
Just to follow up on that, we're in the process of scoping a piece of work across the East Midlands with all 10 authorities across the East Midlands to look at this specific issue around people waiting for assessment and waiting for care, to look at how we might address this, and particularly how we engage with people who are waiting for services and with frontline staff to try to understand A, the impact it has, but B, what solutions might be applicable. And we're hoping to start that work in the new year, and we're hopeful that we will be successful in the bid to the University of Birmingham to help facilitate and fund that work. So that's just a piece of work that's sort of in progress at the moment.
Sorry, why Birmingham?
The University of Birmingham hosts an organisation called Impact, which is a research into practice in social care nationally. So we know that they will be seeking expressions of interest shortly for pieces of work to enhance social care delivery. And this is a piece of work that across the East Midlands we'll be looking to put together for a bid into that process.
I just wanted to ask a question, John, really on your musings earlier. So you hypothecated that the charities had actually possibly identified an issue, that there were many more people that presumably were qualifying for care under the Care Act, but for whatever reason were not taking up that care or even knowing it existed for them. And I think you were making passing a thought that it may be that that is where the growth in numbers of people are coming from. The question therefore is begged is, how far down that curve of identification do you think we are? Because if we're only 10% down that curve of identification, the impacts on not just this local authority, but any local authority could be staggering.
I think, I mean, I'm sort of going from memory here, so I'd have to sort of check my facts on this one. But certainly I do recall reports being issued pre-pandemic that were suggesting there were 500,000 people waiting for care or not having their needs met. Now, if you take that 500,000 and then we look at the recent reports, which are suggesting 400,000, those figures are not kind of out with each other, really. They're in the same sort of ballpark area. Now, obviously, not all of that 500,000 or 400,000 people will be assessed as being eligible for care or for state-funded care, certainly. But nevertheless, they are people who are waiting for a determination. And it might well be that a number of those people may be assessed as not being eligible, but may still require some form of support to keep themselves independent outside of the local authority. So I think it's probably fair to say that there are a number of people, a considerable number of people whose needs are either not being met or whose needs are undermet at this current time.
Always like to finish on a high. I think it's clear from the questions that all of us found that report extremely interesting and useful, and perhaps it's something that we can keep on the agenda to revisit, certainly with the facts that have been raised about numbers rather than percentages, and perhaps have a refresh of this when the next data comes through and we got an appropriate gap in the work agenda, because I think it's something we can all see the value of, and it helps us keep informed the system if that meets with members' agreement. Right, thank you. So we're now moving on to the last report for today, which is agenda item 11, which is the consultation on the eligibility for care technology services, as set out in pages 41 to 44. And this time I think John's being joined by Steve Pugh, Head of Service in the Access Integration and Prevent team. And that's a good job title if ever I heard one. So over to you, John.
Thank you, Chair. I shall be very brief on this one, hand more or less straight over to Steve to take members through the report. And if Steve's ready and online, I think he is.
Yeah, I'm online. Yeah, the camera's not working.
I'll hand straight over to Steve to introduce the report.
Okay, thank you, everyone. My computer just seems to be on a go slow at the moment. So, back in early 2021, Cabinet approved a business case for the new care technology service, and that was launched in April this year. It's been very successful. It's made quite a bit of difference to people's lives. We're starting to see some good case studies coming from that. The new service is very different to the old assistive technology service. It's got a whole range of new devices and has a different feel about it in terms of helping people who are at risk of falls, seizure sensors. It's also linked up to a 24-hour monitoring service. So if someone has a fall, they can press the alarm, or some of them are activated on a fall, and then immediately we can get through to a monitoring service and provide what's called a response service to that person. Medication dispensers and sensor pads, and also alerts for people who are at risk of wandering. So very much a sort of more interactive, more proactive service than it was before. The older assistive technology service was going into someone's home, more or less, and I am generalising, and then putting in pieces of equipment that could help them. This, as I say, this is very much a much more modern service. The other aspect of the services is provided on an eligibility basis. So that's someone who has eligible needs under the Care Act or is likely to do so in the next 6 months. And obviously, you know, they need to be over 18 and live in Leicestershire. Anyone who isn't eligible is signposted to alternative support. So, as I said, the service has been running well. Very pleased with it, the way that it's going. It's got a lot more to offer. But what we have got is we've got a lot of legacy equipment that was previously installed under the old assistive technology. And an awful lot of that, well, first of all, it was provided on a universal or discretionary basis. And an awful lot of that was provided to people who are deaf or hard of hearing. And we continue to get calls, probably about 90% of the calls from people who've had that equipment in the past want some sort of repair or maintenance of that legacy equipment. And that can be anything from the batteries have gone in their doorbell or their smoke detector, right the way through to something that's actually broken and needs replacement. So we're finding ourselves in the situation whereby the demands on for repair and maintenance of the old equipment continues. We're trying to focus on delivering the new service. So the repairs and maintenance side of it is not really sustainable as that demand increases. So it's proposed that we look at the repairs and maintenance side of this legacy equipment and go out to consultation. So if someone is deaf or hard of hearing, they come to us and they're assessed as having a care and support need, then we would look to see how care technology can be part of that support package, and the service will be continued to provide it for them. So, for example, there's an example in the report in paragraph 9. If someone is eligible, susceptible to falling, our assessor installer would look to install both falls protection and the hearing loop as well. If someone comes to us, whether they're deaf, hard of hearing, or anything, and they're not they're assessed as not having eligible needs, then any future maintenance or repair would not be provided by the council, and we'd signpost people to alternative support. So some data on paragraph 11 about we've installed about equipment to about 1,300 people who are deaf and hard of hearing. And as I said before, requests for repairs and maintenance generally to replace batteries or replace defective equipment. So the proposal is that we go out to consultation for the next 4 weeks to seek feedback on the proposed cessation of this universal discretionary repair and maintenance service and apply the same eligibility criteria to anyone who approaches the service for support. In particular, we want to seek the views of the members of the deaf and hard of hearing community. They've already been in touch with us. We've already responded to Action Deafness. We've already had a discussion with a small representative group about how we could best engage. And then in the interim, we will provide the service until at least the end of the year. And then once we get the results of the consultation, we will then present those results back to Cabinet with options to take the service forward, or however we can run that service.
Thank you for that. Any questions? I suppose my only question would be is that I always think on these, if we're going out to consultation, it would be useful for this committee to see a copy of the consultation document. I mean, if it's going out on the 11th, it must be ready. And therefore one would have thought that a copy could have been attached as an appendix. And the reason I say that is that consultation, sometimes I think the public are quite cynical over consultations, and sometimes it's important to put the right phraseology in there to explain what's behind the consultation. Otherwise you're always accused of making the decision prior to doing the consultation because we haven't made it clear what the consultation element is for. And I do think there's an element where members could assist in that. So I mean, I don't know which members, if any, have actually seen the consultation document. At the very minimum, one would have hoped the portfolio holder had seen it. But if not, one would query why not. But I'm sure Christine may wish to comment on that. But certainly I know we've had this on several occasions where either we get a report after the consultation's already gone out, so there's no point. But on this one, we actually had a 4-day window. So we could have actually seen it. And it might have been useful had we had a copy. And I don't know if there's any reason why we weren't supplied with a copy.
I don't think there was any particular reason, and I'm sure that we could email a copy to members of the committee ahead of commencement of any consultation. We're happy to do that and take any comments or feedback before we go out. If members would want us to do that, we're happy to do that.
It is in its final tweaks, as it were. Had a meeting earlier on with our data and BI colleagues. So again, you're quite right in terms of the phraseology and some of the questions. They've got a wealth of experience, so They're just making the tweak. So yeah, we should be able to get something before we, well, hopefully tomorrow.
I think apart from that, we all understand the logic. We all remember the earlier report, so we've got no issues on that. It's just this, as I said, it's sometimes how you phrase it, because it's what does the person believe they're being asked to respond on that might actually make a difference to any decision that could be made. And I just think sometimes that's where local members can help, because with all due respect to officers, we tend to look at this more from the point of view of the person receiving it, which I know sometimes, I don't think officers do it intentionally, but sometimes when you're that close to the work, you sometimes, perhaps miss that aspect. And, all we want to do is work as a team and assist. So I'm sure people will be grateful to receive that. In the absence of any further questions, that brings to an end the substantive reports. The date of the next meeting will be on the 23rd of January 2023 at 2 p.m. So presuming I'm on a bound as almost the first committee to wish people a Merry Christmas and a Happy New Year. There are no other items that we consider urgent. So thank you for which I think it's been a very good meeting this afternoon, with lots of pertinent and very well informed and asked questions, which I think has given us an insight into the future work programme as well. So thank you all. It's actually decided to work now.